In this video capsule series, we discuss the first-line treatment strategies for the management of locally advanced metastatic urothelial carcinoma in Canada.
Well, hello, everyone. My name is Dr Blais, and I'm the first speaker and moderator for this activity tonight, dealing with first-line locally advanced and metastatic urothelial carcinoma, discussing evolving treatment strategies. So the objectives for tonight is to discuss in a Canadian environment what the needs and unmet needs are for patients with locally advanced and metastatic urothelial carcinoma. We're going to have a keynote speaker discussing the new options that are going to be hopefully soon available for patients as a potential upgrade to what we're doing right now in our practice. And we're going to discuss eventually in the discussion period how these data translate into a Canadian environment and how these will impact our current patterns of practice. I will be discussing the current standard of practice in Canada. First of all, I'd like to remind you of some historical data published in 2019. The JUMOC was the site of the birth of consensus guidelines for our Canadian environment. And we've published 4 years ago a guideline on how to manage patients with locally advanced and metastatic urothelial carcinoma. And while it's still interesting to read a lot of things that are in this document, a lot of things are now past their prime, because many new options are now available for these patients. And that's one of the first good news. We often talk about platinum eligibility when we talk about treating patients in the first line. This is much more important in the neoadjuvant and adjuvant space, because we feel that cisplatin is definitely a key player in that setting. Carboplatin and non-platinum options are less interesting in the perioperative space. But it's still quite important for GU oncologists to try to guess who are the best players to receive cisplatin compared to carboplatin. And in the Canadian setting, as you will see, platinum ineligibility is bad news, because there's no immunotherapy options as there are in other countries worldwide. So this translates to an algorithm that looks like this. Patients with locally advanced or metastatic UC in Canada are guessed or are planned to receive either cisplatin or carboplatin. In Canada, it's about a 50-50 split. Cisplatin is preferred for historical reasons, and I'm going to maybe bring some suggestion that it might not be as relevant as it used to be. And keep in mind that most patients that do receive first-line chemotherapy have difficulty receiving second-line options, because this type of cancer can evolve very rapidly, and most patients have complications that prevent them from getting second or third-line options. So I do tend to think that their first-line option is the best option they will receive in the course of their disease. So coming back to the cisplatin issue, it was felt that cisplatin-containing doublets had more interesting long-term outcomes, having a potential plateau for 10 to 15% of patients, as you can see in the left figure of this slide, compared to carboplatin in the two right figures, where there was not such plateau after 2 or 3 years. So it was often felt, because of these types of curves, that cisplatin might have an advantage. And I'll come back to that in a few slides. In terms of activity, we do see that carboplatin and cisplatin derive benefit from most patients having either a response or stable disease, that we can see in 70% roughly of patients that we treat in the first line. So that becomes relevant in the maintenance strategy situation that I'm going to discuss later. Just coming back to the monotherapy options with immunotherapy, we have 5-year data from Keynote 052 that is not to be put aside, you can see that at 48 months, some 20% of patients are still living, and most of them are in remission of disease after starting monotherapy. And I've had the privilege of being able to treat patients within that study and off protocol because of particular access to the drug. And for patients that are not platinum eligible, immunotherapy should have a role in the first line space, but we do not have this funded in most provinces in Canada. I'm going to discuss very briefly the addition of IO to first-line chemotherapy. That wasn't shown to lead to statistically significant improvements in survival, so that's not an option in Canada. I'm bringing the Danube trial comparing IO to first-line chemotherapy only to show one interesting finding from that study is that when you look at the outcomes of patients that have received cisplatin and carboplatin, that's the middle, that's the right-sided figure, you can see that there's a plateau in the carboplatin and cisplatin group. So that old notion of what's better, cisplatin or carboplatin, might not be as important as can the patient get platinum therapy, and potentially can patients access immunotherapy in a second line or even in the maintenance setting. And that probably is the most important contribution to the late outcomes of our patients. And that's leading me to talk about maintenance therapies that you know very well now in the urothelial cancer world, coming to light by data from the Javelin Bladder 100 trial, showing that adding avelumab after stable disease or responding to therapy can lead to very significant overall survival gains. The hazard ratio from the latest analysis was 0.69, very marked differences in survival that has led to widespread adoption of this practice of using avelumab after chemotherapy. Looking at subgroups from that study, you can see that the platinum partner used in the first-line regimen did not change the late outcomes. Patients that had response or stable disease had similar outcomes. You could argue that potentially PD-L1 positive patients had a slightly better gain, and that's probably the case, but negative patients still had a benefit from that strategy. So there wasn't any stratification factors that really gave us the possibility of selecting patients based on any of these different characteristics. So we tend to treat everybody the same with maintenance avelumab when they're eligible for immunotherapy. Those are the data for PD-L1 breakouts, negative and positive, as you can see here. And just reminding you that Javelin 100 is the biggest trial to show maintenance benefits with immunotherapy, but a smaller phase 2 trial that randomized pembrolizumab to placebo, so very similar findings, really sustaining the idea that this strategy is really helpful for our patients. So in the end, we have an algorithm that is that can resemble this, one where we either select cisplatin or carboplatin when patients are platinum eligible. The difficult situation is when patients are not platinum eligible. In my hospital, I try to get some access when I can to single agent pembrolizumab or atezolizumab. Some patients do have insurances that can cover that, but for most patients, that is not an option. And patients will then move on to avelumab if they're stable or responding. And patients that are progressing after first-line therapy will also have the option of using second-line immunotherapy with pembrolizumab. Most Canadian provinces now have access to enfortumab vedotin, so that's our third option and second-line option for most patients. And taxanes are now really rarely used in third line or later lines of therapy. One few words about erdafitinib. For those of you who were at ESMO last year, we've seen a positive trial showing the benefit, or maybe it was ASCO this year, sorry about that, showing erdafitinib benefits for FGFR positive patients. So that's an option that might come into play later on, but the molecular diagnosis of that strategy is still not standardized across the country. So my last slide is really the unmet needs for Canadian patients. I'd like to see better access to diagnosis, better access to primary care and specialized services, because patients get to us really late in the care path. I'd like to see better access to molecular diagnosis. I think we need to be better at selecting patients with specific drugs when we can. So that is to be improved upon. Platinum eligibility is still an issue because we don't have access to immunotherapy in these patients. And the new player in the field is the access to adjuvant nivolumab in certain provinces in the country, and that will change the care path for patients progressing after neoadjuvant chemotherapy or adjuvant immunotherapy. So that might change the path of care.